Hello everyone, and welcome to today's session of A to Z in ENT. I'll be talking about otitis externa, otitis media, and associated ear pathology today. So I'm sure you all know that the ear can be divided into outer, middle, and inner ear. We'll only be concerning ourselves with the former two today. We're also going to go take a step back and just talk about how we examine the ear. So we have instruments to do that. Otoscopes are the first that probably spring to mind. We do not use the otoscope as is depicted in the top left-hand corner there. We actually, so we turn on the otoscope. There's various ways depending on the model, usually by twisting it at the top of its body, and then it should be held like a pen with the little finger extended like an affected tea drinker and touching the patient's cheek. This is great because it gives you an early warning when the patient wants to turn their head. This is particularly useful in children, but also in chatty adults. And so the way you hold it is the right hand holds the otoscope for examining the right ear and vice versa. We also have microscopes that we can use, and they allow us to perform interventions while examining, as you see in the bottom image here. The trouble is sometimes you look down the ear canal and all you see is earwax. It's actually a problem that affects about 5% of the population to the point where they do need to come seek help. So what is earwax? It's a mixture of shed keratinized epithelium combined with secretions from both the ceruminous glands and sweat glands. How do we manage this? So there's various methods. Drops are probably the most effective, such as sodium bicarbonate or olive oil or hydrogen peroxide, 3% made up with water. But then irrigation systems and mechanical removal are great as well. So different patients have different preferences. So once we've removed the earwax and we can actually see the tympanic membrane, this is what you should be seeing if the tympanic membrane is normal and healthy. If you're using an otoscope, you often won't see the whole of the tympanic membrane. So we examine each quadrant of the ear individually and sort of build up a picture of the entire drum in our mind's eye. But you should have a clear, whole, non-perforated, non-erythematous drum that's lying flat. It shouldn't be retracted or bulging in any way. We'll talk about what causes those things in a second. Or in a few seconds, because first we'll begin with otitis externa, which is the infection of the external ear canal. It may be either diffuse, involving all the skin of the external meatus, or be localized as a furuncle. So the patient may have a history of local trauma, or they may vehemently deny a history of local trauma. Patients do like to stick things in their ears, and then small abrasions do lead to infections. You can have severe pain and edema associated with it, or if a furuncle is a form of folliculitis, so this is a singular painful swelling, like a boil, that's always found in the outer ear canal where the hair follicles are found, and never in the inner bony meatus. So, typically it's caused by either Staphylococcus aureus or Pseudomonas aeruginosa. Pseudomonas is the prototypical otitis externa pathogen, and OE is often referred to as swimmer's ear because you do pick up Pseudomonas in wet environments. But you can also have, particularly in older and immunocompromised patients, you can find fungal infections such as Candida and Aspergillus species, which, Candida, you'll get very white, creamy, curdy secretions, whereas Aspergillus you'll see hyphae and you'll have brown and black deposits, as you see in the pictures there. So once you see some form of suppuration and swelling of the ear canal, the patient's presenting to you with significant pain, the first step is to swab it. We send off swabs. Then you suction out as much as you can. This often provides a little bit of relief, but it's also often very tender for the patient, so they may not like you while you do this. But you then apply drops. So antibiotics are, in our trust, our poison of choice is Silodex. So it's ciprofloxacin and dexamethasone. Sometimes you can also get gentamicin and dexamethasone. With gentamicin, you have to be careful that there really is no perforation of the drum. So if you can't see the drum, try and stay away from gentamicin, because it can actually lead to ototoxicity if it gets through the tympanic membrane. If you suspect fungal infection, then await swab results specifically, unless you're very, very convinced. But dotrimazole is a useful antifungal for that. And it's good to remember that drops will be needed for longer, typically in these cases, so 2 weeks. After symptoms resolve, the patients will still need to continue taking the drugs. Of course, as with all of the antibiotics that I'm going to mention throughout the rest of this presentation, please be aware that it's always best to check your own microguides, trust guidelines, whatever it is that you use. These are just sort of the most common drugs that we have experience with. The other option then, if the external ear canal is very swollen and you feel that the drops won't actually get to the whole of the canal, is to insert a Pope wick, which is a little cotton or synthetic elongated square thingy, which, that was very scientific, I apologize, but basically it acts as a sponge and it facilitates the drops reaching the back of the canal. So Pope wicks, you should remember that it is a foreign body, so you will need to remove it after 2 days. And then you can either replace it with another one, or perhaps after those 2 days, after regular drops, with the steroids and with everything, once the inflammation has calmed down, you won't even need it. So the patient can then continue with just the drops. Or you'll need several, and then you'll need appointments for those patients every couple of days. Systemic antibiotics are advised only if there's a fever or a lymphadenitis, and recurrent otitis externa flares should be investigated. So often these are diabetic patients, and it's something that bears a second look, particularly because we can develop malignant otitis externa. So the name is sometimes a bit of a misnomer. It's not malignant because it's has anything to do with cancer in any way. It's because it's quite deadly. So MOE has a 50% mortality. It's also known as necrotizing otitis externa, and it's when the external ear canal infection extends deeper into adjacent tissues, so cellulitis or skull-based osteomyelitis. It's typically a disease of the elderly, diabetic, or immunocompromised, and the infection invades the bones at the base of the skull, and it can present with facial paralysis and other cranial nerve palsies. And basically it's the classic presentation, though, is night pain. So it's severe otalgia that's so bad that it wakes them up in the middle of the night, and something that may suggest the presence of OE is that previous treatment hasn't improved it. The causative agent is typically Pseudomonas, and other possible clues on examination are granulation tissue in the cartilaginous part of the ear canal, polyps, or a myelitis filled with purulent discharge, but that's not very specific, so it's more the constellation of everything together. Again, different trusts have different guidelines, so please consult your guideline. This is what is used at Queen Alexandra Hospital in Portsmouth. It's the basic gist is CTs, then nuclear scans if that doesn't work, and then adjusting antibiotics in accordance with what the imaging shows and with therapeutic response, basically. But either way, for you as the SHO, you'll do the initial suction, swab, and possibly the biopsy of a polyp. Probably not. At that point, you'll probably have involved your registrar, depending on how confident you are. But it definitely is a condition because it is so potentially deadly. It'll be referred to you as an emergency, and you will be involving your seniors very early on. Having baseline bloods, including CRP, to monitor disease progress is great. And starting the patient on peroral ciprofloxacin or whatever the trust equivalent is, as well as topical treatment is recommended right away. Ensuring sufficient analgesia is important, and arranging urgent CTs, whether as an outpatient or inpatient, depending on the patient's state. Typically will be outpatient. And microsuctioning regularly is advised, and these patients should be followed up very closely. If they're not being kept as an inpatient, then regular telephone checkups. And if it has been confirmed that they do have it, then they will need IV antibiotics. So normally about 6 weeks of IV antibiotic therapy. During COVID, we were doing variations of that, like first 6 weeks of oral and then reviewing the response, but I think that slowly that's being phased out again. And discussing with otology consultants, microbiologists is always good. It's not something that you should hesitate to do. Our next section is on acute otitis media. So this is a condition that's typically treated by GPs actually in the community setting. It's not typically something that an ENT doctor will see, but for completeness' sake and because of the associated very important complications, we'll go through it anyway. So it's an acute inflammation and infection of the middle ear. It's typically associated with a history of upper respiratory tract infection, and you get severe ear pain, decreased hearing, and fever. The tympanic membrane will typically be erythematous, bulging, and sometimes you can see pus behind it, or when the tympanic membrane perforates, you can see pus coming through it and discharge coming out of the ear. It's usually, so it's described as a throbbing pain before it perforates, and then once it does, the patient typically experiences a great amount of relief. So what causes it? It's usually, it's the usual suspects in upper respiratory tract infections: Streptococcus, Haemophilus, Moraxella, and various viral infections. Basically, the pathophysiology is that the eustachian tube becomes obstructed as you get mucosal swelling and exudation, and then causing a negative pressure to develop initially, and then as you have more and more exudate forming in the closed off space, you suddenly get significantly increased pressure and at the suppurative stage, and this leads to bulging of the drum and severe pain. And then eventually this can either resolve or it can coalesce, and you end up with long-term problems, which we'll get to in a second. So as I said, GPs manage this slightly differently, and then we have different guidelines in the hospital from other hospitals. So again, everyone, please refer to your own guidelines, but typically the antibiotics are given for about 5 days, and it's something basic like amoxicillin or erythromycin. If the tympanic membrane perforates, the discharge should be collected and cultured, which may be helpful in later stages if it doesn't resolve or if it becomes recurrent. So it's good to have that microbiological information. Analgesics are great or essential really because these patients are in a lot of pain, and warmth is said to improve the pain as well. Acute otitis media can be recurrent, so that's defined as more than 3 attacks within 6 months. And this should then lead to a discussion about whether myringotomy with grommet insertion would be worthwhile, or adenoidectomy in smaller children. Long-term antibiotic use isn't quite the preferred method, but it is an option as well. What you can develop, especially if you have recurrent attacks of otitis media, is glue ear. So it's otitis media with effusion, and it's caused by a combination of infection and a non-functioning eustachian tube. So children often have more horizontal, narrower, and shorter ET tubes, and what happens is that predisposes them to these infections. If they develop glue ear, then because the ossicles aren't transferring sound as they normally would when the middle ear is full of fluid, it leads to impaired hearing, and this can then have the effect in children on poor speech development, occasionally balance problems as well. So the pathophysiology of that is that you actually get a negative pressure as the tube becomes blocked. And after some time, the middle ear fills up with this gluey secretion, retracting the eardrum. And then this is why you don't have the proper transfer of sound as well. How do we manage it? 50% resolve spontaneously, but grommet insertion is quite a popular choice of management, as is adenoidectomy. And you can see why in this lovely diagram here. Adenoidectomy helps. It's because it just clears up the opening of the ET tube. So, what we're interested as ENT doctors is the complications, right? Because these are the things that we see in the hospital most of the time. So, chronic suppurative otitis media is an inflammation that's lasted over 12 weeks with discharge. And the tympanic membrane is abnormal. Typically it occurs in children. The child is well and afebrile, but they do have conductive hearing loss. And it's often, so part of the tympanic membrane has perforated. You can have erosion of the incus or stapes, and you just have this ongoing inflammation. So how do we manage it? So we need to remove debris from the ear by suction. Topical antibiotics sometimes help, but typically the definitive treatment is surgical because the missing part of the tympanic membrane has to be opposed to close the defect. So this is done under general by an otologist consultant. Cholesteatomas are very much related in the sense that you can have, when you have attic and marginal perforations of the tympanic membrane, they can be associated with cholesteatoma. So a cholesteatoma is an abnormal accumulation of skin squamous epithelium within the middle ear cleft and mastoid air cells. So it typically has the appearance of a sac that communicates with the ear canal and is usually pearly white. It has a tendency to progressively enlarge and can erode the bony structures of the middle and inner ear. It can also spread outside it and cause further complications. So this is how the cholesteatoma can spread, as you have a buildup of the cells within the retraction pocket or associated with the perforation. So how do we treat it? We can do a cleaning of the ear, microscopy, targeting the retraction pocket to remove the keratin, but typically this doesn't resolve it. Topical antibiotics and steroid drops may help a little bit, but again, typically this needs to be reviewed and carefully monitored, and in the end it often does require surgery. So mastoiditis is our next complication. It's an infection of the mastoid air cells, which will lead to severe earache with tenderness, swelling, and redness behind the pinna. And the pinna may look as though it's been pushed forward, making it look more prominent. It's good to look at the non-affected ear for comparison. You can often, in true mastoiditis, you can often see a difference. So it's a disease of small children mostly, so typically the patients are younger than 2 years in age. You can also get it in adults, but typically they're very elderly, diabetic, and or immunocompromised. It very rarely occurs in young, healthy people. The causative pathogens are similar, Streptococcus, Haemophilus, staph, and we diagnose it through high-resolution CT or MRI together with the clinical findings, and the reason we do the imaging is to rule out intracranial complications. The way we manage it is with antibiotics. If you have intracranial involvement, it will have to be longer. If it's non-severe, then you can give antibiotics just orally. Otherwise, if you have to give IV antibiotics, and if you suspect intracranial extension, then you need something with a good penetration, like ceftriaxone. And then surgery is necessary when you have very, very bad cases. So, we then move on to facial nerve palsy, which may be associated with a number of these conditions, specifically if there's dehiscence in the bony covering of the facial nerve in the middle ear and the inflammation spreads to it. However, before we talk about all that, we need to differentiate between the different types of facial nerve palsies. So just remember that if there's any forehead involvement, any signs of upper motor neuron palsy, then please, it is not ENT, refer it to medics. It may be a CVA. So that needs to be looked at by somebody from the medical team. Lower motor neuron palsies are very commonly Bell's palsy, so it's an idiopathic cause. It could be middle ear pathology, as we're about to discuss, or it can be associated with rashes. And so Ramsay-Hunt syndrome is varicella zoster of the face, and including a facial nerve palsy. So look for vesicles, especially hidden in the ear. And Lyme disease can also result in a facial nerve palsy, so look for the classic bullseye rash in these patients. So those are differentials. But if you're convinced, if the patient has a good history of a recent upper respiratory tract infection and ear pain, then it could be that the inflammation from the middle ear has been transferred to the facial nerve because the covering of the facial nerve was not completely intact. And so what happens? So it's a temporary paralysis. Lots of these patients recover. And however, it is quite distressing for patients when they can't move half of their face. So we give corticosteroids, intravenous antibiotics if we do suspect that it is infectious. And if you can see on otoscopy, you see that you have a bulging tympanic membrane, then actually myringotomy and grommet insertion can relieve the pressure and resolve the facial nerve palsy much faster. Surgery is indicated when there's a suspected silent or mastoiditis. So the facial nerve palsy can be an important warning sign of a severe hidden case of that. So other things I wanted to mention, the discharging ear, discharge itself, think about where it might be coming from. So is it coming through a middle ear perforation, or is it coming from the myitis itself? So it may come from the skin of the external ear canal, the surface of the tympanic membrane, or the lining of the middle ear cleft. So discharge from the middle ear cleft is profuse and mucoid in nature because of the mucosal lining of the middle ear, so just keep that in mind. And then let's just think about referred pain as well. So not everyone who comes to us with ear pain actually has ear pain. If the external ear canal and the drum are normal, and if you use a device that I haven't shown you, but it's a pneumatic speculum, and you can see that there's normal movement of the drum, then the pain can't actually be coming from the disease, from a disease process of the ear. So if it's intact, it's intact. So then at that point we need to start thinking about where the pain could be being referred from. So it could be from the oropharynx via the glossopharyngeal nerve, for example, from the tonsils, or from a carcinoma of the posterior third of the tongue. It can be coming from the upper molar teeth, TMJ, or from the parotid gland through the trigeminal nerve. So parotid causes are usually pretty obvious. Impacted wisdom teeth may not be, though, so keep that in mind. And temporomandibular joint problems can be assessed using things like seeing whether the patient has limited mouth opening or changes to their bite, differences with, whether they have problems grinding their teeth or something like that. And then the cervical spine, C2 and C3. So pain coming from there is often worse at night when the head lies awkwardly, and the neck support often provides relief. So using a neck pillow, if that relieves the ear pain, then maybe somebody should take a look at the patient's neck. All right, and then finally, my favorite, foreign bodies in the ear. So if you have particularly a child, but sometimes also hearing aids, or just randomly if a bug crawls into your ear, then there are various methods for removing that foreign object. So you can use a hook, you can use suction, or microcrocodile forceps. In the case of insects, if they're still moving around, the patient's likely to be very distressed. A good move is to drown the insects with saline and then pull them out. So there's various things that you can try. If you have light foamy objects, for example, then suction is perfect for those. So just be creative, but keep in mind that with children it's very difficult. So after a failed attempt, maybe discuss with your reg or consultant if theater removal is more appropriate, so that you don't actually damage any delicate part of the ear more than it already has been by the foreign body. Okay, so does anyone have any questions?